Good morning and welcome to Medical Grand Rounds. We're going to begin. Before introducing to the speaker, just a reminder that if you want credit for Medical Grand Rounds, please send us an email at the address listed below. And we also provide maintenance of certification credits for this Grand Round. So if you send us an email, we'll send you a link to a few questions that have been validated and that you should be able to answer if you pay attention. So next week will be Grand Rounds by George Joshua, one of our chief residents, rare diseases and how to find them. And the week after next will be the Samuel Cushland Visiting Professorship by Dr. Talley, and talking about gluten sensitivity. A reminder that we have no commercial support for Grand Rounds and no conflicts of interest. And now for the case of the week, Brian will present. Brian?
Thanks, Gary. All right. There we go. Fred, it's an honor to be your opening act. I'll keep this tight. All right, so cases, we have Mrs. C. She's a 64-year-old lady who's presenting with neck pain and worsening left eye pain. She was in her usual state of health until 1 week ago when she developed neck pain after eating. This pain is described as a 6 out of 10 aching, constant, and localized over the left lateral aspect of her neck. 1 day ago, her left eye became acutely swollen and tender to the point where she was unable to open it, denied any purulent discharge. Past medical, surgical, family history is non-contributory, no allergies, no meds, and social history is fairly unremarkable as well. The exam, I've kind of highlighted the things that I want to focus on in red. She's febrile, her left eyelid is hard and tender to palpation. She has some tenderness to palpation over her left sternocleidomastoid. For a neuro exam, her left eye is fickled. She has some pain with extraocular movement, papilledema, and a left afferent pupillary defect. On basic labs, we see that she has a leukocytosis with a neutrophilic predominance. The team, when they met this patient, was deeply concerned about an orbital cellulitis / orbital compartment syndrome, so they promptly consulted ophtho, who came down and measured her intraocular pressure, which was 3 times the upper limit of normal, so they actually relieved that pressure pretty acutely with a lateral canthotomy, which bought some time to figure out what's going on. They followed smoke to the fire. And I'm going to show you guys a CT orbit through a coronal view, and if you're anything like me, you are not comfortable with reading coronal views of CT orbits, which is fine. All we need to pick up on is that there's an asymmetry here between the 2 eyes. I'll even give you guys a cheat sheet. What I really want to focus on are these 2 circles. The one on the patient's right is a normal superior ophthalmic vein, and the one on the patient's left is an unenhanced, dilated superior ophthalmic vein. Same CT orbit, now we take it in an axial view, and we go on up, and it becomes even more prominent to notice this change. Now, instead of showing you guys the interpretation, we could just kind of point out what's here. We see some eyelid swelling on the left, some proptosis on the left as well, congestion of the retrobulbar fat, and then very subtly, this asymmetry in the cavernous sinus that was concerning for a cavernous sinus thrombosis. But the team was unreconciled. They felt like this wasn't where the narrative began because the patient originally showed up with neck pain and not eye pain. So they went on to pursue a CT soft tissue neck. So we have the aortic arch here. And if you go back to our first year anatomy class, we have the branches of the aortic arch. So in the middle, we have our common carotid. I want you guys to keep your eye on that. We're going to play a 3-card Monty really quick. So follow that, follow that, follow that. And what we have here is our internal carotid juxtaposed next to our internal jugular. And what you notice is on the left-hand side, there's a lack of enhancement in your left internal jugular vein. Blood cultures came back as fusobacterium. You couple that with the IJ thrombus, and this is now diagnostic for Lemaire's syndrome. So this is a septic thrombophlebitis of the internal jugular vein. The pathogenesis is actually fairly easy to show in pictures. The patient presumably had some local trauma while eating. The normal flora from the mouth then seeded and made its way to the IJ, which, because of bacterial endotoxins, formed as thrombus, which causes a whole slew of problems. The take-home here is that if you see an IJ thrombus associated with fusobacterium, it is Lemaire's until proven otherwise. This almost always hits the lungs, so be concerned. If you're going to get a CT of anything, extend it down to lungs. And in decreasing frequency, you can hit the bone. CNS is what ended up being the complicating and the cause of death in this patient. This retrograde propagation into the cavernous sinus, which eventually ended up causing innumerable abscesses in the brain. Treatment is antibiotic protracted course because it's seeded now into a thrombus, so it will take some time. Source control if necessary. If that doesn't cut it, surgical intervention. And anticoagulation is not approved. And there's small data sets that show that it can actually help if you see retrograde extension. So shout outs go to John, Salmaz, and Kelly for taking care of this very sick patient.
Good morning, everybody. It's my pleasure to introduce Dr. Fred Howard to give his first medical grand rounds. Fred is from Illinois originally. He went to Cornell, where he pulled off the extraordinary feat of a triple major in computational biology, chemistry, and economics, and a minor in biomedical engineering. I don't know how you did that. He then went to the University of Michigan, where he was a standout medical student. He graduated AOA and actually founded his own medical software company while he was there. So I assume you're extraordinarily wealthy as well, because he sold that company. And he came here in 2015 to be a medical resident. Fred stood out from the start. He's exceedingly smart, compassionate, hardworking, and a role model, not just for his peers, but for all of us. He graduated with a distinction in medical education. We were thrilled that he accepted the opportunity to become a medical chief resident. A lot of the residents probably know that one of Fred's accomplishments while he was here was also to do a design of the CPRS system at the VA, which allows decision support for complex data that has, I think, been used over 20,000 times. But among all these accomplishments, I really think that one of Fred's finest is actually that he married Kathy Gao. So you want to see a power couple of extreme intelligence who are going to transform American medicine. They're sitting right next to each other. Fred is going to be going to the University of Chicago next year to be a hematology oncology fellow before he returns to Yale to join the faculty. Anyway, Fred, welcome to the podium.
Thank you for that very kind introduction. So let's get started. I have no financial disclosures to report yet. So let's get started with a case. Our patient is a 40-year-old woman who found a nodule on breast self-examination, and she presented to her primary care doctor. She denied any skin discoloration or abnormal discharge, and on exam, she was noted to have a firm, non-tender nodule in her left breast and no axillary lymphadenopathy. She was referred for mammography, which revealed a 3-centimeter spiculated nodule concerning for malignancy. This was biopsied, revealing a moderately differentiated infiltrating ductal carcinoma, which was estrogen receptor positive and HER2 negative. Now I want you guys to imagine that you're seeing this patient in an oncology clinic. And you're seeing this patient in one of the 50 hospitals reportedly across the world that have implemented Watson for Oncology, an artificial intelligence decision support tool to aid in treatment decisions for patients with cancer. So you decide to review the case with Watson. This is a representative interface. It's not actually the most recent version, but it gives you an idea of what the software does. First, relevant information is pulled from the EHR, including demographic data like age and gender, laboratory data, and clinical characteristics. And then a series of treatment decisions are given, or treatment recommendations are given, including options for chemotherapy, including associated outcome and toxicity statistics, options for endocrine therapy, and the ability to refer to surgery and radiation. So artificial intelligence is being implemented in medicine, and it's going to change your practice in the future, whether you're a primary care doctor or a specialist. So how can we prepare to practice medicine in the 21st century? Well, first we're going to talk about some of the basics of artificial intelligence, and by that I mean the nuts and bolts. But we're going to keep it really simple. Next, we're going to talk about how AI is used across all domains of medical practice, from diagnosis to treatment. And then finally, we'll develop a framework to evaluate these tools so we can best use them to help our patients and ourselves. So let's get started with some of the basics. Artificial intelligence refers to any kind of machine imitation of human cognition. And this concept has existed for millennia, but formal scientific progress towards this ideal really began in the 1940s with Warren McCulloch and Walter Pitts, who described the artificial neuron in 1943. This became the basis of what is now known as neural networks. Warren McCulloch was actually a Yale graduate and did some of his work here. In 1950, Alan Turing described one of the first measures of machine intelligence, which he referred to as the imitation game. In this test, an interrogator would be tasked with distinguishing a human from a machine using only written answers and questions and responses. This later became known as the Turing test. In 1956, John McCarthy, an associate professor at Dartmouth, hosted a conference dedicated to the study of artificial intelligence. And he's credited with being one of the first to formally use the term AI to refer to the study of thinking machines. There were many fruitful years of research in AI, but then in 1973, James Lighthill published a highly critical report about artificial intelligence, stating that in no part of the field had the discoveries made thus far produced the impact that had been promised. This led to the defunding of AI research in all but 3 British universities and marked a decline in AI known as the AI winter, which lasted, like Game of Thrones, for many years. But in 1990s, the research in AI was revitalized due to an explosive growth in computing power, which is illustrated by Moore's law, which states that the number of transistors in a microprocessor would double every year. And so we can see that this held true over the years on this logarithmic scale graph, indicating an exponential growth in processing power. And this has enabled modern-day applications of artificial intelligence.
Ken, you're in the first position. Please make a selection.
I've never said this on TV. Chicks dig me for 200, please, Jimmy.
Kathleen Kenyon's excavation of this city, mentioned in Joshua, showed the walls had been repaired 17 times. Watson.
What is Jericho?
Correct.
But I'm willing to bet that most of you haven't been on Jeopardy. And if you have, you didn't play against Watson. So what kind of impact does AI have in our daily life? Do any of you guys use AI or work with AI on a daily basis? Can I get a show of hands if you do? So I see some hands, but for those of you who didn't raise your hands, I'm wondering if you thought about the recommendations you receive on sites like YouTube, Netflix, or Amazon, or Facebook's facial recognition software, or the automated ads that you get on Google. So AI may be pervasive in our daily lives, but what about our medical practice? Can I get a show of hands for those of you who work with AI on a daily basis in medicine? Got a handful there. So for those of you who didn't raise your hands, I'm wondering if you thought about the fact that every time you send off a CBC, the automated differential is read by a machine. Or the fact that the majority of pap smear specimens don't reach the eyes of a pathologist because they're screened by artificial intelligence. And in the past year, there have been numerous FDA-approved applications of AI. Let's talk about a few of them. So imagine you're seeing a patient in the emergency room who's very altered, and you order a head CT. By the time that patient is wheeled back to their room, you get a message from MaxQAI's intracranial hemorrhage detection system that alerts you to a potential brain bleed. This allows you to confirm the results with radiology and expedite neurosurgical care. Or suppose you're seeing a patient in clinic with very poorly controlled diabetes, and you've been asking them year after year to get an ophthalmologic exam for retinopathy. But this year, because you implemented IDX's diabetic retinopathy detection system, you're able to tell the patient they have severe vision-threatening retinopathy, and they are finally agreeable to ophthalmologic referral. Or perhaps you're seeing a patient with COPD who got started on steroids, and now their blood sugars are out of control. You go in to tell the patient this, and their response is they'd like to increase their Lantus from 8 to 12 units because they've used DreamMed's Advisor Pro software and inputted their finger sticks and gotten a recommendation for their insulin regimen. Or finally, maybe you're seeing a patient who's hypotensive, and being the diligent internist that you are, you put an ultrasound probe to their chest to look at their squeeze of their heart. And although the ejection fraction looks normal to you, you're very reassured because your hospital has invested in Bay Labs' Auto-EF software that tells you that the EF is 66%. So there are numerous applications of AI in medicine. But there's really a subset of AI that applies to most of the applications that we see in clinical practice, and that is machine learning. Machine learning refers to any kind of algorithm that continues to improve as it's exposed to and fed more data. In other words, with supervised machine learning, you feed in a set of data into a black box, and you get some kind of output. Now, this could be the clinical variables of the CHADS-2 score and giving you a stroke risk. This could be unstructured data in EPIC giving you a risk of sepsis. Or it could be an X-ray giving you the presence or absence of pneumonia. And supervised learning occurs when you feed in a large set of training data for which the outputs are known, and you compare the algorithm's outputs to the known result, and you use that to continually improve your algorithm. So let's take a look at how that works with a simple example. Suppose you have a bunch of patients with diabetes. You know how much soda they've drank, and you know their blood sugars. You can imagine the relationship would look something like this. So with machine learning, you might start with an estimate of what you think this relationship would be. It's inaccurate. It's an overestimate of what the glucose would be for how much soda they consumed. And you look at the error in your estimate. Then you slightly vary the parameters of your model, make the line flatter or more steep. And you can see that the model would be more accurate if it was a little bit more flat. So you make a slight adjustment, and you reassess. You reassess again until you arrive at a more accurate estimate of this relationship. And that's how most machine learning algorithms continue to improve with data. Now, there are other ways to do a linear regression problem. So what kind of models are actually used in machine learning? In other words, what's inside the black box? Well, from a review of papers published in PubMed, there are a couple algorithms that predominate. And those include logistic regressions, neural networks, and support vector machines. Now, some of these terms may be unfamiliar to some of you in the audience here, but I just want you to have heard them so that you feel comfortable as you're approaching artificial intelligence research in the future. Logistic regression refers to the use of a kind of sigmoid shaped curve to model dichotomous data, or yes-no data, or binary data, such as the presence or absence of diabetes in relation to one's BMI. The support vector machine does a similar task. Again, modeling dichotomous data. In this case, the white dots indicating patients with diabetes in relationship to the BMI and soda consumption. And a support vector machine identifies the best way to separate these two classes of data with a line like this that allows you to classify new data points that come about. But if you look at recently approved applications of artificial intelligence in medicine, a lot of them use neural networks. So I'd like to spend a few minutes talking about them. But first, let's refresh how an actual neuron works. The signal starts in a presynaptic neuron, and that reaches a synapse. At the synapse, neurotransmitters are released which either excite or inhibit the postsynaptic neuron. And that excitatory signal might travel down to the axon hillock. If it exceeds a threshold, an action potential is generated. You might imagine that a single neuron doesn't generate a signal that can exceed the threshold. But if you have multiple excitatory neurons, it might exceed the threshold, generate an action potential, and give you an output. This is a lot like how neural networks are actually designed. You take a series of inputs into a model. Instead of using synapses, you assign weights to the model that can be positive or negative if the signal is excitatory or inhibitory. You take a weighted sum of those inputs, and if it exceeds a threshold, you generate an output. Instead of using a discontinuous function to model that threshold, you might use something a little more continuous, but that's basically how neural networks work. So we talked about the models used in machine learning, but there's one other concept that I'd like to highlight to you, and that's the concept of deep learning, which refers to using multi-layered neural networks to identify complex data. Let's look at one last example. Suppose you have a bunch of patients who are hypotensive, and you've collected two variables about those patients, their ejection fraction and how much saline they were resuscitated with. And you want to be able to predict which of these patients did well and which of them had a bad outcome. You might imagine that there's a set of patients who had low EFs but got flooded with fluid, and they might have had a bad outcome. There might have been another set of patients with normal EFs who were under-resuscitated, and they could have had a bad outcome. So let's look at how you could actually model data like this. You could take a single neuron for your neural network, feed in those two input variables, and take the output as an estimate of survival. Now, if you actually train a model to do this, it does something like this. The orange part of the graph indicates the area the model predicts would have a bad outcome, and the blue area represents the area the model predicts would have a good outcome. You can see it does a very poor job at distinguishing the two. But what if we added another layer to the network? What would happen then if you trained the model? You can see it does a much better job. And why is that? Well, we can take a look at what the individual neurons are doing. The one on the top here is identifying the patients in the top right who were adequately fluid resuscitated. And the neuron on the bottom here is identifying patients in the bottom left who had heart failure and were appropriately not given a lot of fluid. And you can kind of take a linear combination of those two to identify the patients who survived much more accurately. And this continues to improve as you add additional layers to your neural network. And that's really the power of deep learning, that you can improve your accuracy and model really complicated data with deep neural networks. So we introduced a few terms: artificial intelligence, or the machine imitation of human cognition; machine learning, or models that continue to improve as you give them more data; and deep learning, the use of multi-layered neural networks to identify very complex patterns in data. So now that we know some of the basics, let's talk about how AI is used across all domains of medical care, both to highlight that it can be used really to approach any medical problem, but I also want to inspire you to use some of the freely available public software to use some of these approaches in your own work or research. So I'm going to focus on a series of cases in the field of oncology to narrow my focus. And it's not just because of my fellowship aspirations, but if you look at AI literature in PubMed, articles in the field of oncology really predominate, although there are publications in really any field of medicine. And I'm also going to talk about how AI is used across every part of a patient's journey through the healthcare system. When you first see a patient in clinic, you're tasked with arriving at a diagnosis, and AI has proven exceedingly helpful in aiding in this task. Deep neural networks have been used to classify skin lesions as benign or malignant, to highlight areas of cancer on large pathologic samples, or to identify abnormalities on all manner of radiographic imaging. Once you arrive at a diagnosis, you have to give an estimate of disease severity, both to inform your patient of their prognosis, but also to inform your own treatment decisions. In oncology, artificial intelligence has been used to predict survival from large clinical databases. It's also been used in genomics to help identify the complex relationship and interplay between multiple mutated genes. And finally, you have to prescribe a course of treatment. And I think prominent examples in oncology include IBM's Watson for Oncology, as well as radiation oncology software that has been used to minimize the dose of radiation needed to achieve a desired shrinkage in tumor size. So let's start with an example in diagnosis. Melanoma represents about 5% of all skin cancers, but it accounts for 75% of skin cancer-related mortality. And early diagnosis really matters. If you diagnose early stage 1 melanoma, 5-year survival can be 99%. But if the diagnosis is delayed till stage 4, that drops down to 14%. And early diagnosis is impaired by lack of access to care. It can take over a month to get a dermatology appointment. So one potential solution is to use neural networks and AI to help diagnose these skin lesions without a dermatologist input. Now, we talked about a few simple applications of AI, but how could you even begin to approach a problem this complex using the tools that we mentioned? Well, again, you can think about how your own eyes recognize objects. Light reaches the back of your retina and stimulates rods and cone cells in response to the light and dark and color. And that information is then passed to ganglion cells, which identify areas of contrast. In the visual cortex, multiple areas of contrast next to each other can identify simple shapes like lines, and then more complex shapes. And as you travel down the visual cortex, you begin to identify areas of border, or border that's highlighted by white space, or border that is highlighted by differences in texture. That information is combined with information about hue and curvature to identify simple objects in the inferior temporal cortex and more complex shapes as well. In other words, you identify increasingly complex pieces of information as you travel through the brain. So the way you could approach this is very similar to what we talked about with deep neural networks. You can identify increasingly complex patterns of information with deep layered neural networks. So, for example, you could feed in the individual pixels and images of animals and then identify First, simple features like lines and the borders of these pictures. And then more complex features like the presence of whiskers or a fluffy border, a small nose, might identify that this object is a cat. And thankfully, brilliant researchers have been working on this problem for years, and there exist a lot of public models that address this problem and can identify many simple objects from cats to dogs to dishwashers to airplanes. But what if we took one of those publicly available models and fed it pictures of melanoma and benign nevi? Well, you would get kind of complete nonsense, like a sheep or something that looks kind of like a melanoma, perhaps, because basically the model doesn't have the language to describe what a melanoma is. In other words, the model can identify that a melanoma is asymmetric, it has notched borders, it's got variegated color, but it can't identify, it doesn't have the language to describe what a melanoma is. So it picks maybe whatever's in its vocabulary that looks closest. So what some researchers at Stanford did was take that last layer that says, what are the features that make up a cat and what are the features that make up a dog? They removed it and put in another layer and that specified what is a melanoma, what's a basal cell cancer. And they trained it to identify what are those complex features that make up each skin lesion. And then it can correctly identify skin lesions. Now this is what that publicly available model actually looks like. And it's exceedingly complex, but you don't need to know about that. It's a big black box developed by Google. The researchers fed in a bunch of skin lesions into this black box and then again replaced that last layer with a series of diagnoses. They trained it on over 100,000 skin lesion images. And then they fed it some biopsy-proven image samples and compared its performance to that of dermatologists. You can see individual dermatologists listed as those red dots and the model's performance listed as the blue line. And you can see it outperformed the average of 21 dermatologists on biopsy-proven images. This is to dermatology what Watson was for Jeopardy. This could really revolutionize the field. You could imagine that a patient takes a picture of a skin lesion that they see and immediately gets a diagnosis of whether, or immediately gets information about whether they need to proceed to biopsy or whether they have a benign lesion, which could reduce the burden on our healthcare system and speed up referrals. So what did we learn about this software? Well, we learned that deep neural networks, because of their ability to identify complex features, really excel at image recognition. Large data sets, like in this case, over 100,000 samples, can improve model accuracy. The researchers use something called transfer learning, taking advantage of all the progress that's been done in image recognition to power their model. And I also want to highlight that these are all open source tools that you could use. It's as easy as putting images into a folder on your desktop. And so I did something like that myself. I found a database of 400 white blood cell images, and this is a problem that other people have solved, but you find 400 white blood cell images, I put it into the exact same model, and I classified them into 5 basic classes of white blood cell images. And I trained it. You can see the validation accuracy is shown on the blue line here. And I was able to get relatively easier an accuracy of 95% on this data set. And it's pretty cool. You can put in images of monocyte, and it's 98% confident about that. Images of basophil, 89% confident. But most importantly, it answered a question that I've had for years, and that's, what kind of white blood cell am I? I guess I'm a lymphocyte. Anyway, and that's something that you can all do at home, and I'm going to show you how at the end of the talk. So stay tuned. Next, let's talk about an example in prognosis. Like melanoma, breast cancer survival is highly variable. And choice of treatment depends on how severe your disease is. You want to be able to give people who are more likely to recur with their breast cancer aggressive chemotherapy. There are large definitive databases of cancer statistics of patients in the US, hundreds of thousands of patients who've had cancer in the past. But the best way to use the information in those databases to predict survival of future patients, I think, is a little bit unknown. A lot of tools currently use logistic regression, but one paper a few years back compared the performance of a logistic regression to neural networks to predict survival using one large US database called the SEER database. We compared logistic regressions and neural networks. So what the study did is they modeled 5-year survival with 17 clinical variables from SEER, including grade, stage, and tumor size. And they found that with over 200,000 cases analyzed, there's about a 2% improvement with survival prediction with neural networks, which was statistically significant. And once again, I want to highlight that doing a neural network on a large database, developing a neural network on a large database is as simple as using any other statistical software. And there's freely available tools to do the same on your own sets of data. So I did the same analysis with more recent SEER data, and I got very similar results. And just a few percent difference between the two models, but again, statistically significant. So if neural networks outperform logistic regressions at this task, what's clinically used now? Well, there's a couple models used to help predict survival in breast cancer. For example, we can think about the PREDICT model, which is a logistic regression-based model that was trained on a large UK database. And we can think about genomic tests like Oncotype DX, which use a linear combination of gene expression to predict prognosis. So if neural networks outperform logistic regressions or more simple models, why aren't they used in actual practice today? Well, one big problem is a lack of validation of the neural network models. Just no one's really pushed them through and, I think, evaluated them thoroughly with actual patients. The other thing is simple models work pretty well for less complex data. There's only a small number of input variables here, and we can see the performance benefit isn't that great. The other thing is simpler models are a lot easier to interpret what's actually going on underneath the hood. For example, with the PREDICT model, you can see, based on the hazard ratios associated with the model, that detecting a lesion on screening is good, whereas a large tumor size is bad. Or with Oncotype DX, you can see that estrogen receptor expression is good, whereas HER2 expression is bad. But perhaps in the future, as we develop more complex prognostic models that include genomic information as well as unstructured EHR data, we'll begin to see neural networks or deep learning approaches being used. So one last example here regarding the treatment of disease. Cancer is very prevalent. About 4 in 10 people will be diagnosed with cancer in their lifetime. And while cancer diagnoses are on the rise, so is the amount of medical literature we have to review. Some studies estimate that doubles every 5 years. With all that information to review, it's no wonder that it can take up to 15 years for most recent medical literature to disseminate across practice. So one solution that was proposed was IBM's Watson for Oncology to individualize treatment with AI. Now, what that software actually does, again, and it's probably the most black box about any of the softwares that I've discussed thus far. But what IBM's Watson is supposed to do is take a series of demographic variables, laboratory data about disease, as well as histologic and genomic data, and reference it against over 300 full-text medical journals, as well as NCCN guidelines to provide a treatment recommendation. And when this model was developed, it was trained against synthetic cases developed by experts at Memorial Sloan Kettering until it achieved a 95% accuracy on those synthetic cases. There's few studies looking at its performance in the real world, and all of them that look at Watson's performance look at something called concordance, which refers to how often Watson's treatments agreed with a tumor board. In this case, if Watson's recommended or first choice chemotherapy regimen was the same as the tumor boards, it's listed as green on the graph. And if Watson even just listed as a recommended regimen what the tumor board recommended, it's listed as yellow. And they sum those two to count as concordance. So with breast cancer, there's some studies reporting 93% concordance with tumor boards. Lung cancer, 66%. And colorectal cancer, 87%. So you might say not bad, but if you look at what people actually think about the use of Watson, it paints a different story. Internal documents from IBM state that medical experts working with the model have found multiple examples of unsafe treatment recommendations, such as a patient who had a recent episode of major bleeding who was prescribed bevacizumab, which has a black box warning for major bleeding. One expert said that Watson for Oncology is still in its toddler phase, and we just need to kind of wait and engage, and maybe someday it'll be helpful. And one Florida doctor said upon testing the product, it was a piece of shit. And really, although Watson is used internationally, it's not used in any academic center in the US. So why did Watson fail to make a splash? Well, it shows a very complex problem to tackle. There's so many treatments in oncology, and it's growing, and treatment options are growing in oncology faster than any other field of medicine. I think that the training on synthetic test cases posed multiple problems. So one, it was a real struggle to update, according to Watson's lead trainer at Sloan Kettering, Mark Chris, because every time a guideline changed, you'd have to go back and tweak these made-up test cases to reflect actual practice. And it's hard to imagine that synthetic test cases that doctors came up with could really reflect the diversity of disease in actual practice. There's no way to see the inner workings of Watson and see when it might be accurate or less accurate, given its black box nature. And finally, I think the hype around Watson really exceeded any kind of actual validation. So if you think about it, sure, Watson's first choice recommendation was the same as a tumor board in, say, 60% of cases in patients with breast cancer. But of the 40% of cases where Watson's first choice recommendation was something different, there's no real quantification or validation of the harms potentially performed by the module or inaccuracies. So in summary, we talked about how deep neural networks are phenomenal at classifying images. We talked about how currently prognostic models use simpler machine learning techniques like logistic regressions, but maybe in the future we'll see deep learning approaches. And we saw how the use of a limited number of test cases instead of big data to train a model led to problems with validity. So now that we've seen how these approaches can be incredibly successful or sometimes underwhelming, how do we evaluate these tools before putting them into practice? Well, first you need to take a look at the data, and data is essential for any machine learning approach. I hope that I'll have illustrated to you through the examples I've given earlier and some of the tools I'll provide at the end of the lecture that you don't need to be a brilliant programmer to use machine learning in your research. But what you do need is data. According to a survey of thousands of machine learning experts, dirty data or the lack of high quality data is rated as the biggest barrier to the implementation of AI. And large data sets allow you to have increasing accuracy, which is problematic with medical data, which is often incomplete or inconsistent, as highlighted by estimates of error in electronic health record data seen on the right. But even if you have high quality data, if the data doesn't reflect the question you're trying to ask, you might end up with bias in your model. For example, selection bias refers to when individuals in a study don't reflect the population as a whole. And that's not a unique problem to artificial intelligence, but it applies to any kind of data science project. For example, you can think about the Framingham Heart Study, where the initial cohorts enrolled largely European Americans, raising questions about the validity to other ethnic groups. But bias in machine learning can be much more subtle. Imagine that you want to predict which patients with chest pain require cardiac catheterization. You might develop an approach that models its behavior after actual clinicians, but then you run the risk of propagating bias and error that occurs in actual practice today. For example, one large study had a series of actors of various races and genders give a history of chest pain that was exactly the same. And they had physicians rate which patients should go to cardiac cath. And they found that white male patients were more likely to be referred for additional invasive testing. So we have to be very careful as we bring these models into practice that they don't reflect biases that actually exist in healthcare today. Another type of bias that exists with machine learning is something called funding bias. Suppose you have a model that gives you choices of multiple different treatment options, or gives you recommendations on treatment options. And suppose the developers of the model have a financial investment in the makers of drug A. Then you might imagine that they could be tempted to alter their algorithm or train it in such a way that it favors drug A over drug B. And given the opaque nature of AI, it can be very difficult for clinicians and regulators to identify this kind of bias. So make sure that the data that is used to train the model really reflects the question at hand. And then take a deeper look at the model itself. And by that I mean take a look inside what's inside that black box, which model is used. And how can we identify which model is most appropriate for a problem? Well, if you don't have many input variables, then a simple model might be best, at least to start with, something like a logistic regression or a linear regression, as it's much more interpretable. If you have a lot of complex input variables, but you don't have much data, that's one situation where support vector machines actually excel. And if you have big amounts of data and you're dealing with something very complex, maybe a neural network is the best approach. But if you're assessing a paper, what if you can't look at that model? What if it's a trade secret? You know, in essence, a neural network is defined by the structure of relationship between the different nodes in the network. And that's something that's very easy to transmit from one computer to another so that other people can apply your model. However, this is rarely done in academic research, which I find very surprising because of how easy it is to implement these models. Maybe it's because it's a cultural thing, or maybe it's because journals don't have the infrastructure set up to host these models. Maybe it's because researchers are looking to make a financial gain off of them. But when you don't disseminate the actual model itself, I think it really does slow the scientific progress that's central to academia. You can still validate a black box or industry-sponsored model in concert with an academic center, but if you're a provider working with a unique group of patients, it might make it more challenging to make sure that that model works in your unique clinical situation. And finally, the more opaque something is, the harder it is to understand. I think the harder it is to trust. So I would urge that if you're using AI in your research or you're reviewing others' research that use AI, really try to get more models actually published in the literature. So after thinking a bit about the model, most importantly, you need to make sure that the tool you're using is validated in the real world. Eric Topol is a cardiologist and a machine learning enthusiast, and he laid out the following framework last month for the validation of AI in healthcare, and I think it's pretty accurate. So when you're first developing a machine learning model, you train it on huge sets of data, and it's traditional to take some of that data and keep it hidden from the model, so that once you're done training, you can validate it on data that it's never seen before. You can publish those results. Next, because training data often doesn't reflect the variability of clinical medicine, you need to test your model in a real-world setting and use actual relevant clinical endpoints. And this data should again be published for physicians to review. And then the developers should seek FDA approval and finally implement the model in healthcare. But let's take a look at some of the recent FDA-approved models. You know, which of these have academic studies that kind of support their use? Well, actually, only 2 of them have published studies in PubMed, and it's questionable even if these represent examples of actual clinical validation. And I illustrate this to you just to know to be careful and carefully assess how well the tools you're using have been validated in actual practice going forward. Once tools actually reach our practice, I think one other thing a lot of people wonder about is liability. Who's going to be held accountable for adverse events that occur? What if you listen to an AI and something bad happens? You know, who's going to be responsible for that? Is it going to be the developers of the model? Traditionally, the answer is no. Most decision support tools used in actual medical practice are designed to be used under the supervision of physicians who can decide if the model is appropriate for the clinical scenario that they're in. So it'll be up to you and the healthcare system you work in to make sure that the models that you use, the AI tools that you use are appropriate. I think another interesting question is, what if you ignore AI and AI was right? You know, should physicians be held liable for that? And I think intuitively you might say, you know, clinical judgment needs to reign supreme in actual medical practice. But if you only listen to AI or decision support tools when they tell you to do what you would have already done anyway, I think you will never actually unlock all the power AI has to offer. For example, if I had a dermatologist tell me a skin lesion was benign, but that software I talked about earlier said it was malignant, I might be still interested in a biopsy. So when you're assessing these tools, think about the data used to train the model. Think about the model itself, and make sure that it's been rigorously validated in clinical practice. We talked a lot about ways that AI outperforms physicians in this lecture. So I think a lot of people wonder if we're slowly going to be phased out and replaced by machines. But I think most people believe that's not going to be the case. We have unique skills of negotiation, dealing with real patients, and dealing with actual people in real life, and solving complex problems. So doctors are rated as one of the least likely professions to be automated. But there's a staggering amount of AI tools in development for medical practice right now. And I think it's no doubt it'll change the way that we practice. So you might see a patient and review data collected by a PhysIQ sensor. You might talk with your patient, and instead of writing a note, software developed by Seikera will document your conversation in the EHR. And instead of ordering a colonoscopy, you might order Freenome's cell-free DNA analysis to identify if your patient has colon cancer. So even though AI may not replace us in the future, it will fundamentally change what it means to practice medicine. So, and you'll be well equipped to handle this future because hopefully you've understood some of the basics of AI. You've seen how it can impact care from diagnosis to prognosis to treatment. And you have a way to evaluate these tools before putting them into practice. So let's get back to our case. You're reviewing a patient with breast cancer with Watson for Oncology, but you decide to close out of the software and use more traditional, well-validated machine learning tools, such as the logistic regression-based predict model, which says that your patient has a 5% 10-year mortality benefit with adjuvant chemo. You send off genomic testing with Oncotype DX, which suggests a high risk of recurrence. So you prescribe your patient doxorubicin and cyclophosphamide followed by paclitaxel. But you look forward to the future advances that AI will bring to give you more time to do what you do best, to be a doctor for your patients. I'd like to thank all the faculty that helped review my talk and the support I've had from my chiefs, my wife, my family, and all the friends that I've made at Yale. And